now I am. I'm sorry, Gabby. Can you repeat that, please?
We were talking about the difference between, I think, sepsis and increased intracranial pressure.
Huh?
And so for increased intracranial pressure, the blood pressure, especially systolic, increases, and then the heart rate and respiratory rate decrease, it's opposite for sepsis, where the blood pressure drops and respirations and heart rate increases.
You got it. That's exactly right. It's the exact opposite of sepsis. All three of them. Perfect. So I know by now y'all know what vital signs do when we're talking about sepsis and infection. So if you know that and you just think of the exact opposite, that'll help you remember what happens when the pressure in your head builds up. Alrighty. So let's shift our gears just a little bit and go back and talk about maternity and newborn and focus on that for today, unless y'all have questions about pediatrics. Absolutely. I welcome your questions on pediatrics, but we will go back and talk about postpartum and newborn. So let's see. What does bubble he stand for? Anybody remember? Bubble what? Yes, breast, that's the first one. Bladder. Bubble he. Our postpartum assessment. Yeah, let me see if you got, let's say we've got breast, bladder, uterus, bowel, lochia, episiotomy. Y'all hit all of them. Very good. Perfect. So breast, uterus, bowel, bladder, lochia, episiotomy, home and sign, and emotional status. So let's talk about what all those. It's okay. No, that's one we don't do anymore. So let's talk about the different categories. So the breast assessment is going to be asking about, things like breast tenderness, firmness, redness. While they're still in the hospital, it is highly unlikely that they're going to have mastitis that quickly. But engorgement, absolutely, is very much a chance that they will have engorgement. And typically, the one of the big differences you'll see between engorgement and mastitis is that engorgement is going to be both breasts versus mastitis is more likely to be one breast or the other. Engorgement is just the milk coming in. It's overpressurization of the breast, for lack of a better term. But your mastitis is an infection that we treat with antibiotics. So when we're talking about breast assessment, looking again for the redness, the tenderness, the firmness, the heat. That's the word I was looking for. Increased temperature. So also teaching the parents the mom, how to care for her breasts, whether she's breastfeeding or whether she's bottle feeding. So if she is breastfeeding, both groups, whether they're breastfeeding or bottle feeding, should wear a good supportive bra, because that will help with both. If you are breastfeeding, you want more stimulation. So nipple stimulation, using warm water, using heat right before they feed for 15 minutes can help with milk flow. But stimulation, we want stimulation. Versus if they're bottle feeding, we want no stimulation. Yes, exactly. We can use cold or ice or cabbage leaves, decreasing stimulation, so turning their back from the water to the water instead of letting the warm water spray onto their breast. Both of them wearing, again, a good supportive bra, but keeping them non-stimulate. I know. And that is, usually when we think of cold cabbage leaves, we think of bottle feeding. The biggest difference between the two would be time. So, because the cabbage leaves will decrease milk production, so it's good to use for comfort. However, you have to be careful if they want to breastfeed how long they're using it for. So if they want to use the cabbage leaves and they're breastfeeding, it's okay to help with the pain. But yes, exactly. Use it after feedings and not so frequently, because it can decrease their milk production if they use it too frequently. So they can be used. They just have to be mindful of how often they're using them. Now, if they're bottle feeding, just leave them on your breast if you want, but cold and decreased stimulation. Yes, and watching out for mastitis in both populations. It's more likely you're going to get mastitis with breastfeeding, but there's a potential you could get it in your bottle feeding, and making sure they know the signs and symptoms of mastitis as well, the pain and firmness and redness and things like that. Yes, very good. So with mastitis, they should be breastfeeding, but or at least pumping. They need to empty their breasts in some way. It's fine to breastfeed unless they have an abscess. If they have abscess formation, then they should not be. Very good. See, y'all do know it. Yes. In fact, some women will say it's way too painful to actually breastfeed, and they have to use manual expression, where they actually use their hand to express the milk out of their breasts, or even using even a pump can sometimes be too painful, depending on the severity, but they have to get it out of their breasts some way, form, or fashion, because it's going to get clogged and it's going to make it worse. If there's an abscess, then that's different. But just run-of-the-mill mastitis, still continue to breastfeed, because that's going to help baby too. Mom has an infection. When mom has an infection, she's producing antibodies. She's not passing the infection on to baby. She's passing antibodies on to baby, which is going to strengthen baby's immune system and give baby some extra immunity. Just like when women are sick, like with flu and cold and all that stuff, they're encouraged to still breastfeed because they're passing on those antibodies to their baby. If you ever look at breast milk side by side of a woman who is perfectly healthy versus a woman who has an illness, it's much, much darker in color in the woman that has an illness at the time, because it's got more antibodies in it. It's interesting how our body can adapt. So that's our breast. So our uterus is going to be the most important body part we are assessing in this mom, because the chance of death is greatest related to this body part. Postpartum hemorrhage is the greatest cause of postpartum mortality. So assessing the uterus for firmness, as well as location. So it should feel firm and not boggy. Boggy means it feels soft. And where should it be located right after birth? Where should we expect to find it? Yeah, so right at or just above, so no more than a centimeter above the umbilicus. A lot of times it is about a centimeter above the umbilicus, but you don't want it well above the umbilicus. 3 or 4 centimeters, that's too much. But right at or right above the umbilicus, midline, and firm. So it should recede about 1 to 2 centimeters every 24 hours. So about each day, you should have 1 to 2 centimeters lower than it was the day before. Until about 2 weeks postpartum, you can no longer feel the fundus. So if it's boggy, not going to the restroom, if it's boggy, what's the first thing we do? If it's just boggy but it's midline? Yes, massage. Now, if it's boggy and deviated to the side, then what are we thinking? Then we're thinking bathroom. So when you see to the side, think they need to pee, because that bladder is pushing that uterus up and pushing it off to the side, causing it to be displaced to the side. So our interventions for this: 1, fundal massage if it's boggy. 2, looking at if she needs to void is another thing that we're looking at, especially with deviation to the side. So the uterus, consistency and location. So bowel and bladder, I'm just going to kind of combine together. We don't assess these any differently than we do in any other patient. So asking them if they void, when's the last time they voided, things like that. Asking them when was their last bowel movement. Seeing if they have any hemorrhoids, which that kind of falls more under the episiotomy, because that's when I have this gnat that's driving me crazy. Sorry, y'all keep seeing me pinch the air. It is if they have hemorrhoids, although that kind of goes with the episiotomy, as far as because you're looking at the perineum. So they're more prone to constipation, more prone to urinary retention, especially if they've had a epidural. So assessing for those, but also assessing for as far as your bladder, looking at diuresis. So if they're voiding frequently, they're having polyuria, is that normal or abnormal? That's fine. That's fine. It's fine. It's like 2020. It's fine. No, it really is. It is fine. Yes, unless they're having dysuria with it. If they're having painful urination with it, that's a problem. But if they're just voiding frequently or having large amounts of urine when they void, that's okay. Their body is just trying to get rid of that extra fluid that it built up during pregnancy, that extra 50% of fluid. So diuresis, diaphoresis are fine. So bowel and bladder, again, we're not really assessing any differently than we would in other patients. It's just they have a higher risk of having complications than your typical population. So the L kind of fits with your uterus. That's your lochia. That's your vaginal discharge. You're bleeding, at least initially. So how long does the lochia rubra last, the red discharge? Yes, very good. Up to 3 days. Yes, checking for under their buttocks, making sure we're having them either lift up or roll over or something, so we're making sure that they're not having blood pooling up underneath them, because that could be easy to miss. So 0 to 3 days for your lochia rubra. The 3 to 10, very good. That's going to be your lochia serosa, which is like a pinkish color. And then your lochia alba, up to about 2 weeks, is going to be your 2 to 3 weeks is going to be your last one. So if you think about it, the lochia rubra correlates with after pain. So we talked about after pains, the pain that women have in the cramping pain that they'll have for 3 days postpartum as their uterus is trying to contract back down. Also lasts about 3 days, the same amount of time as you have the lochia rubra. So those are time frame wise the same. Yes, so if it lasts too long, or if they go backwards in color, that could indicate retained placental fragments, or it could indicate an infection. Yes. Yes, exactly. Uterine acne, lack of tone. Something is causing that uterus not to come back down the way it needs to. And placental fragments will do that, because if you got something blocking it, then it can't contract back down. It could also be other things that can cause uterine acne. Let's say they had some medications during pregnancy, like mag sulfate. You got your preeclamptic patient that got some mag sulfate to prevent seizures. Well, the meds haven't quite gotten out of her system yet, and now her uterus doesn't want to contract because it relaxes. Any patient that had yes, definitely main concern with macrosomic babies is your blood glucose. They can get hypoglycemia, absolutely. When we're talking about your risk for uterine acne, and that also includes your macrosomic baby. So if you have a macrosomic baby, because the extent that uterus had to stretch, that's more that it has to contract back down to stop bleeding. Polyhydramnios, anything that makes the uterus stretch overly more than typical, increases that risk of postpartum hemorrhage. So think of the amount of room it has to stretch, or if there are things that are preventing it from contracting back down. So lochia, like y'all mentioned, serosa is up to 3 days. I'm sorry, rubra is up to 3 days. Serosa is up to 10 days. Alba up to 2 weeks, 2 to 3 weeks. Making sure it's not going backwards. And that the after pains, that kind of falls in with that too. The after pains are up to 3 days, where you get the postpartum cramping, especially with things like breastfeeding, because it's causing a release of oxytocin, which is causing the contractions. It's the body's way of trying to make the uterus contract. They're normal for the first 3 days. If they continue past that, that's concerning, because you shouldn't continue to have cramping after 3 days. As far as the lochia, as far as amount, not necessarily knowing, the mils associated with scant, small, moderate, etc. Anything that's heavy is concerning. Moderate or less, that's okay, especially if they're newly postpartum. Moderate or less is an appropriate amount. Yes, they should be counting the pads. Every time they go to the restroom, they should be changing their pad, but they also need to be having an idea of how saturated they are, and how many they have. If they saturate a pad within 15 minutes, that is considered postpartum hemorrhage. And I know in the hospital, as far as for clinical purposes, we tell you if they've saturated in an hour to let the nurse know, but clinical definition is if they've saturated in 15 minutes. Yes, very good. So with postpartum hemorrhage, one of the medications that we give is oxytocin or Pitocin. You've probably heard them call that. Same thing. Oxytocin is your generic. So that helps with uterine contraction. So the big four drugs that we use for postpartum hemorrhage, your oxytocin is one. Your misoprostol, which is your Cytotec, that's your other one. That is given usually either vaginal or rectal. Then your methylorgonavine or Methergin, that also helps with contractions. And the last one is your carboprost, also known as Hemabate. That also helps with contractions. So those 4 medications are medications we can give to help stimulate contractions, make the uterus clamp back down. So hopefully they stop bleeding if uterine acne is the reason for the hemorrhage. Now, if that's not the reason, then we need to figure out what's causing the hemorrhage. It could be an unrepaired laceration or something like that. Or it could just be they need to pee. Something else I was going to say. I don't remember. Oxytocin. I'm sure it'll come back to me. I see you typing, Carol. That's when we'll wait. Assess and care what? Oh, that's what we're going through. We're going through the postpartum assessment and the care associated with each section. Compare and contrast what in the postpartum? Assessing, what we need to look, what our assessment is going to include. Your postpartum focused assessment. What's a few days after birth? Oh, yeah. No, postpartum depression is if it continues past 10 days. Yeah, postpartum blues. Yeah, I was going to go through the whole bubble he assessment first so we can keep kind of all that information together. But yeah, we'll go over APGAR. So lochia, we talked about lochia, the lochia rubra, lochia serosa, lochia alba, and when those should disappear, along with when we have after pains. After pains is normal. That's fine. You expect them to have cramping up to 3 days, as long as it doesn't continue past that, because that can indicate either a uterine infection, which is your endometritis, or it can indicate a retained placental fragment, because the body's trying to push it out and it's not going anywhere. So then we have our first E, which is episiotomy. And even if they don't have an episiotomy, this helps you remember to assess their perineum. So looking at whether they have if they have an episiotomy site, assessing for your signs of Rita. Do you remember what Rita means? What it stands for? It's an acronym you can use for any incisions. Yep, redness, ecchymosis, edema. Yep, discharge or drainage. You can use either D word and it applies. And approximation. Excellent. Very good. So that acronym helps you remember what you're looking for when you assess any kind of incision. So whether you're talking about the C-section incision, whether you're talking about the episiotomy incision, that helps you remember what you're looking for to assess if there's complications of that site. So we're looking at when we say E for episiotomy, looking at the perineum, not just for if they have an episiotomy site, but do they have any lacerations that are continuing to bleed, repaired lacerations, for example? Do they have bruising? Do they have a hematoma, especially if they have a lot of swelling? You get concerned with maybe they have internal bleeding. Looking at for things like hemorrhoids, for example, that's usually when we're doing our hemorrhoid check, is looking at the perineum. So then H stands for Homan sign, which it's not a test that we do anymore typically, but it helps us remember to check for blood clots. So checking for symptoms of DVT and RPEs. Yes, exactly. You tell the patient, can you flex your foot back towards your head and have them do it, because that's going to put less force on the back of their calf than you actually pushing on their foot. You can dislodge that clot that way if you push on that foot. So looking for things like pain in the calf, warmth, any kind of, if it's a large enough blood clot, you may even feel a lump, although it'd have to be a pretty large clot. PEs, assessing for things like cough, shortness of breath, petechiae on the chest, low-grade fever, lower pulse ox readings, those kinds of things. Yes. Usually it's going to be the pleuritic type of chest pain. And if you don't know what pleuritic means, it's where it's rubbing, basically. So it'll feel like a sharp stabbing type of chest pain. So our last one is emotions. So when we're looking at emotional status, there's a few things we're looking at. One is attachment and bonding. We want to assess for characteristics of appropriate attachment and bonding, such as is the mom caring for her baby, picking the baby up, talking to the baby, participating, and things like that. If they're not wanting to participate and care, or if they don't act interested, that can be a sign of impaired attachment. So it's our job as nurses to promote that attachment, to say, hey, look at me changing your diaper, look at how they're responding, and it helps them get connected to the way that the baby is responding to touch, and to even newborns have responses to touch and to you talking to them. So attachment and bonding, as well as emotional complications. So there's 3 things we look at in your postpartum blues and postpartum depression have very similar symptoms, but what is the difference in the 2? One of y'all already said it, and I can't remember who it was. Might have been Gabby. Yeah, how many days? What's the difference? What's the cutoff? When this is normal hormonal changes versus this is abnormal. Yes, 10 days. Very good. So prior to 10 days, when they have sadness and crying and those kind of symptoms, it's normal. It's considered postpartum blues. If it lasts longer than 10 days, then that's considered postpartum depression, which is concerning, and they often will need to receive psychotherapy as well as your antidepressant medications. Your SSRIs are probably the biggest category that they use for that. Yes, exactly. With postpartum depression, there's a lot of medications on the market that are antidepressants that can still be used and still allow for breastfeeding, but your antipsychotics, none of them are compatible with breastfeeding. So unfortunately, women that have postpartum psychosis will need to stop breastfeeding because that is definitely a case where their medication need far outweighs the need for breastfeeding. So with psychosis, this can develop at any time. This doesn't have a time frame. This has more to do with symptoms. It is more popular, that's a bad word, more common in patients with bipolar disorder. And it's as they're going into that manic phase that it will manifest. They'll have, why can't I think? Symptoms of
hallucinations.
What's that, Carol?
The book says psychosis develops within the first 2 to 3 weeks with severe clinical findings of hallucinations and attempt to harm themselves or the baby.
Mm-hmm. Yep, so hallucinations is a big part of it, and especially the HI, the homicidal ideations. So they're a harm to potentially themselves and or their child or children or anybody else. So it is very concerning for their safety as well as others. Yes, they'll have with the hallucinations and the psychosis, and they'll get paranoia as well that goes with it, and that's part of the manic phase. As y'all learn about your psych disorders in Mr. Dobbins' class, I'm sure y'all probably talk about bipolar because it's a big disorder. When you're talking about type 1 bipolar, that's some of the classic hallmark signs is paranoia and hallucinations. So might start with those kind of symptoms, and then it manifests into the SI and the HI concerns. So these patients are considered a harm to themselves and or others. Usually they'll get admitted when they have their initial psychotic episode, and then they'll be placed on medication because these are like we talked about in class, these are the women who like drown their children or kill their children. Unfortunately, it's incredibly sad. I can't even imagine living in your mind like that. And having those kind of thoughts. There are some days I can't stand my children and I want to throttle them, but not like that. Yeah, exactly. I can't even imagine what that feels like. So that is our the components of our bubble heat assessment. So kind of to go back as far as postpartum hemorrhage, that is the most common cause of death in your postpartum patient is postpartum hemorrhage. So that's what makes the uterus so important. We talked about the medications for it. We've talked about mastitis. We talked about after pains. So I think we've covered postpartum pretty well, at least in the mama. Any questions on mommies? So let's talk about babies. See, I'll pull this up for the APGAR if I can find it. Where are you? There you are. There it goes. It did not want to play nice with me. Alrighty. What's that, Gabby? We don't really talk about placenta accreta that much. So if you're wondering what, I know y'all probably read about it in your book. This is where the placenta, to put it in simple terms, it gets embedded too far into the uterus, so it makes it harder for it to separate when it's time for it to separate, so it increases the risk of having retained placenta or retained placenta fragments. We won't really talk about those problems, so I wouldn't worry about those, no. There's different categories of it, different levels of it, how severe it is. It can even grow into the actual like muscle itself, not just the endometrial lining. But no, we won't. Don't worry about that. Let me. Sometimes I have to remember where things are located in Collaborate versus Skype, because they're not anywhere near the same place. Let's see. All right, so here is, I'll pull up the picture so that way we can look at it as we're talking about it to make it a little bit easier. So when we are analyzing our APGAR scoring system, we are looking at 5 components of the newborn assessment to determine a quick and dirty assessment of how well a baby is tolerating being outside. We want a baby to have a score of 7 to 10. That means they are doing really well outside of the uterus. And if it's less than 7, then we worry about how much additional measures they need. Well, it could just be that they need a little bit of stimulation, all the way down to they need to be intubated or bagged or whatever it be. So each of the 5 categories gets scored from 0 to 2. Depending on what they're presenting with. So we have our activity, which is also known as our muscle tone. So if they're moving around or if they're fully flexed, this gives us 2 points. If they are partial flexion or half flexion, you'll hear it called sometimes, then they are a 1. If they are limp as a dish rag, that gives us a 0. There's no flexion, there's no movement. That gives us a 0. The pulse one is usually pretty easy because that one is based on a number. There's really no interpretation for it. If their heart rate is not there, you get a 0. Of course, you're probably going to have zeros in a lot of other areas as well if you've got no pulse rate. If it's below 100 beats per minute, it is a 1. If it's over 100 beats per minute, it's 2, which is a little bit different than our minimal fetal heart rate of 110. So this is just a little bit lower than that normal fetal heart rate. So then we look at their response to stimulation, their grimace. So if you go to suction their nares and they don't do anything, they just lay there, that gets them a big old fat 0. They are not responding to stimuli at all. Very concerning. If they have a grimace or if they kind of pull away, then they will get a 1. And if they are crying in relation to in relationship to stimuli, you go to suction their nose and they are crying because it's uncomfortable, that gets them a 2. And I know the terminology on this that you see on the screen, this chart is a little bit different. Go with the terminology you see in ATI. I feel like the terms they use is a little more specific. So the other one that usually people understand pretty well is your skin color. It's either you're completely blue, you have central cyanosis, which is pretty bad. If you have central cyanosis, that's a hypoxia issue. That gets you a 0. What most babies have, even babies that are doing really well, is they get a 1 point for this, and that's where they have the acrocyanosis. So their core will be pink, but their extremities, their hands and their feet, will be blue. And then they get 2 points if they are completely pink head to toe when they are born, which is pretty unusual for most babies. Most babies are not pink when they're first born head to toe. Maybe at 5 minutes, but usually not at 1 minute. And then respirations is not based on a number like the heart rate is. It's based on the cry effort. So if they're not crying at all, they get a 0. If they have kind of a weak cry, then that gets them a 1. If they got a really forceful, vigorous, lusty, strong cry, that gets them a 2. So crying can give you a lot of information. The strength of their cry, as well as if they're crying to stimulation, if they're moving around, that's a lot of your points right there. That's not what I meant to do. Where's escape? Where's escape? Oh, here we go. Maybe. Any questions on APGAR? Y'all feel good about APGAR? Y'all did really, really well on it in class when we went over it. Good, good. I know that's a lot of times people feel a little antsy about APGAR. So let's talk about newborn vital signs. So in a newborn, vital signs and assessment findings, I should say. We'll kind of lump all that together. So what is your normal newborn heart rate? Yeah, 110 to 160. What's your newborn respiratory rate? Yep, 30 to 60. Very good. What's your temperature? Really, temperature is minusculely different from an adult. It's like a hair higher than an adult, so it's pretty much the same. Your pulse ox is going to be the same. Blood pressure is significantly lower. Now, I did tell y'all before, don't worry about focusing on blood pressure too much. We don't do routine blood pressures in children under 3. Unless there is a need to do it. So exactly, 60 to 80 over 40 to 50 is typically what you're going to see in a newborn blood pressure. I wouldn't worry about focusing on blood pressures too much, though. Heart rate and respiratory rate are the 2 big ones that are different than your typical adult that you should focus on. The big thing with your heart rate and your respiratory rate that's important to know is they are irregular, and it's normal. It is fine for them to have irregular respirations as well as an irregular heart rate. Often, and you'll see this actually throughout pediatrics, children will often have what's called a sinus arrhythmia. If you listen to a child's heart rate, you'll hear it speed up as they breathe in and then slow back down as they breathe out. It's very common. It doesn't indicate anything is wrong. And you'll hear it even more so in newborns where it might sound like it almost skips a beat or something. It's not. It's where they are just figuring out how to work, but especially with respiratory rates. Yes, retractions are bad. Retractions are never okay. So irregular respirations are fine. Things like retractions, grunting, head bobbing, all of those are bad. Those are never anything that can justify those things happening. That is your, yes, periods of apnea. Now, according to ATI, period of apnea up to 15 seconds is normal. I will tell you, in practice, we do up to 20 seconds, especially if we know it's a child that has periods of apnea. But per ATI, 15 seconds of apnea is fine. And so irregular periods of apnea, but you don't want to see any symptoms of respiratory distress. Like you said, retractions, grunting, head bobbing, nasal flaring. Obviously, if their pulse ox is decreased or they start having central cyanosis, those are very concerning. Those are some later signs. So if they're having respiratory distress, what could we administer to them to see if it's effective? Not albuterol in this case. I know that's what we think of for older kids and adults. Yes, absolutely. We could see if it's an airway issue. Not racemic. Surfactant. There you go. So, and I know exactly what you're talking about, Bonnie, because you think of that in your older kids, especially with croup. What do? We get them some rack epi to open up that airway. When we're seeing in newborns, though, unless we can identify an airway obstruction, a lot of times it's where they haven't developed enough surfactant to really open up their lungs yet. So we can administer surfactant. Surfactant is administered down an endotracheal tube, so we put it directly to the source in the lungs when we administer it. And then we would observe to see if their respiratory status improves. Let's see, respiratory. Oh, so while we're on vital signs, what's a normal blood glucose in a term versus a preterm baby? Yeah, very good. How about preterm? Yeah, a little bit lower in preterms. Yeah, 30 to 40, a little bit lower in preterm. So full-term babies, usually about 40 or 45, depending on what source you see, but definitely significantly lower than a adult. You start getting less than 70, and you're like, oh, where's the orange juice? But for infants, it's significantly lower. So watching for that blood glucose, what population will we be most concerned about this in? And Gabby actually already mentioned it. I want to make sure y'all remember. If you have a baby born to what kind of mother? Yes, very good. A diabetic mama. This can cause you to have a macrosomic baby, and with the mother having diabetes, and it doesn't matter if it is a pre-existing diabetes or if it's gestational diabetes. Both of those populations have a risk of having macrosomic babies as well as having hypoglycemia. And the greatest risk of hypoglycemia is within the first 24 hours of life, as the pancreas is readjusting to getting this level of sugar, and now it's not getting that level of sugar anymore. It takes time for it to readjust to what level it is getting. So we worry about hypoglycemia, and we worry, and that's in your diabetic patients. Speaking of macrosomia, so diabetic mamas cause large babies, macrosomic babies. What kind of circumstances may contribute to an intrauterine growth restriction or too small of a baby? Absolutely. Drug abuse can greatly contribute to it, especially any drugs that you think of that cause vasoconstriction. So cocaine and tobacco are probably the two that come to mind, or meth as well, that can contribute to it. So because of the vasoconstriction that is being caused by these drugs, it is limiting the amount of blood flow to baby, thereby not allowing baby to grow to their full potential. So IUGR, that is probably one of the big things we think of, but the most common cause, and this is drug abuse can cause this, the most common cause of intrauterine growth restriction is hypertension or high blood pressure, which that fits with cocaine as well as tobacco. The vasoconstriction you're getting from the use of cocaine and tobacco causes high blood pressure. But even mothers that say have gestational hypertension and don't have any kind of substance abuse can also get IUGR because of the constriction of the blood vessels. Another situation that contributes to IUGR is a geriatric pregnancy. You know how I feel about geriatric pregnancies. When they're over the age of 35, exactly. The placenta and the uterus are not going to perfuse as well as somebody who is non-geriatric. So that can contribute to intrauterine growth restriction as well as an older mother, a geriatric pregnancy mother. Those are probably the big ones. IUGR, obviously anything that contributes to malnutrition and whatnot, that can be an issue. Let's see, what would be good? Skin. Let's talk about skin. So normal versus abnormal findings. There's a lot of variations we see in pediatrics or in infant skin that are normal findings. They're just variations. Oftentimes they'll all be lumped in together as birthmarks. Like for instance, Mongolian spots. They're purplish to bluish colored lesions, I guess you would say. You can't really call them lesions. Areas of skin discoloration, yeah, typically on the buttocks or on the back. But you can get them anywhere on your body. And they are permanent. They're not going to go away. They usually lighten up with age, so they're not as easy to see as the child gets older. But there's nothing to be concerned. Yes, African American and Hispanics, they're more common with your darker skin individuals, and they are no concern. There's not even concern that they are connected with any other like genetic disorder or anything like that. They're just a birthmark. That's all. There sometimes is concerns that they can be misinterpreted for abuse, like bruising, which it does happen sometimes, but or even parents will be alarmed when they see them and think that somebody abused their baby. But you know, letting them know that it's normal. It's a birthmark. Another birthmark that you might see is called a telangiectatic nevi. Layman's terms, usually you'll hear this called a stork bite. It's where you'll get the little mark on the back of the neck. It's normal. It's fine. It's not anything that's considered concerning. Now, one thing you do see is hemangiomas. Now, those, depending on the size, can become concerning because as they get larger, they do have a vascular component to them. So they can get large enough to cause pain and cause obstruction to underlying structures. So those might not need to be monitored, but it's going to depend on how big they get. Sometimes they're very small and they really don't mean anything. Milia, which is where you get the little white spots on the face, or little keratin cysts. They're normal. All babies get or not all babies, but a lot of babies get them. It's the overwhelming majority. They are not concerning. They don't go away. Kind of the same thing with your erythema toxicum. That's more common on the chest. That's the one a lot of times you refer to as baby acne. Yeah, exactly. Making sure the parents know whether it's the milia or the erythema toxicum. Don't touch it. Don't mess with it. There's nothing you need to do for it. Don't pop it, because it can cause infection and scarring if you mess with it. But it will go away. It just needs to be left alone.
Is the erythema toxicum
I think that's
the
the
one
biggest
pustule,
skin.
Miss Martinez?
Yes, ma'am.
Is the erythema, what is the one where it's like, if it's one, it's okay, but if it's multiple, that's the problem? I can't remember what it asked you about.
No, if you have, so with erythema toxicum, you will have multiple lesions, and they're often different types, like macules and papules, for example. If you see where you have, pus-filled lesions, your purulent lesions, your pustules, I was trying to look for the word, the pustules, then those are concerning, because that's a sign of a staph infection or a MRSA infection. But as long as you don't have pustules, you're okay. With erythema toxicum, it's often going to be macules, papules, and vesicles, most commonly on the chest, but they could occur anywhere on the body. That's the biggest thing. So as far as skin, so the Ballard scale is what we use to assess their gestational development. So we're using characteristics such as how much lanugo they have, or like the scarf sign where you pull the arm across the chest and how far they can pull the arm, or the popliteal index where you not the wrist. Popliteal index has to do with bending back the leg. There's a wrist. If you do 90 degrees, 45 degrees, you do not need to memorize the Ballard scale. Please don't. It's extensive. Usually nurses, when they do it, they have the scale in front of them where they're looking at it to score it, because it lets you know from a physical perspective what is their gestational stage or age. So that can help you, especially like going back to that IUGR baby, that intrauterine growth restriction, and you're wondering, were we maybe at an earlier gestation than we thought? And then you can do the Ballard scale and see, no, gestationally they're appropriate. They're just very small. For skin, looking at the vernix, so that cheesy covering that they have when they're born, that's great. It's oftentimes they're now, studies have shown leaving it on for longer and not giving them their bath so soon helps to protect their skin. Yes, exactly. Babies who are post-term have very, very little vernix left. Usually it might just be a little bit in the creases or something like that, which it's not going to protect the skin as well if there's not much of it left. What else? I guess this kind of goes with skin jaundice. So if you're looking at their skin, yes, you got two types of jaundice. So you've got your patho. Yes. So pathological jaundice means there's something wrong underlying with the baby that's causing it. So yes, pathological jaundice is when it starts less than 24 hours after birth. So most commonly when we're looking at pathological jaundice, it's where there was that RH incompatibility. So mom did not get RH incompatibility on the previous pregnancy. So maybe for some reason mom did not get her RhoGAM last pregnancy. Maybe she didn't even know she was pregnant. Sometimes you can have losses of pregnancies without even knowing. She had that isoimmunization with last pregnancy. Now this baby, because of that exposure to those antibodies, has caused hemolysis, rupturing of all the red blood cells, which has caused this massive release of bilirubin, causing that pathological jaundice. And yes, that is our big concern. You can get kernicterus with either the pathological or the physiological, but you're more likely to get it with the pathological because there is something underlying that's causing that. So kernicterus is just where you have that buildup of bilirubin that causes brain damage. So it's to the level that it sits on the brain tissue, it aggravates the brain tissue. Yes, and it is irreversible. So bilirubin, to fix jaundice, we can put them under bili lights to help break down the bilirubin so it can be excreted. But once you have damage to the tissues, like the brain tissue, the damage it causes are irreversible. Yes, absolutely. Babies, when they are put on the bili lights, because you want to maximize the amount of skin that's being exposed to the bili lights. So they should be naked except for a diaper. You want to make sure they have eye protection. Yeah, exactly. It's like you're reading my mind, Gabby. You want to make sure they have eye protection if they're under the bili lights where it's in the incubator style. Now, if they have the bili blanket where they're just wrapped in it, they don't need the eye protection because it's not going to be over their face. But they really do, because the eye protection is usually white or black, the coverings I've seen, and it kind of wraps around their head. Usually the ones I've seen kind of Velcro behind their head, and it's got the big old eye coverings, and they do kind of look like aliens. Poor babies. And they stay in that all day and all night. Usually you only take them out maybe an hour a day or so, and it helps break down the bilirubin. But kernicterus, the effects of kernicterus are irreversible. So once they have that brain damage, it's done for. So we talked about in the day class today, for those of you in the day class, that one of the types of cerebral palsy, the dyskinetic cerebral palsy, that can be caused by hyperbilirubinemia or your kernicterus. We also talked about how, back when we talked about newborns, kernicterus can cause problems with cognitive abilities. It can cause problems with vision, and it can cause problems with hearing. So it's all neuro related that it causes problems with. Breastfeeding. So let's talk about breastfeeding a little bit from the baby side of the avenue. So we talked about mom as far as mastitis and stuff like that. We want to make sure they're feeding for how long on each side. Yes, proper latching is super important. Improper latching can cause mastitis. It's one of the most common causes of mastitis. Yes, so typically 10 to 15 minutes per side. Or like you say, sometimes you don't make it that far because baby fills up, but that's great. 10 to 15 minutes per side, alternating which side they start on each time, because if they're starting on the same side every time, then it is going to cause a unequal production. Yes, exactly.
What's the lip thing the babies get that's hard for them to make it hard for them to latch or something?
What's
like
that?
What's the condition? It's something like about when the baby's mouth is kind of messed up, it makes it hard for them to latch or something.
So if they have a tight frenulum, which is the little thing under your tongue, if it's larger, then it causes them not to be able to open their mouth as wide, which means they can't form an appropriate latch. To be an appropriate latch, you have to take in all of the nipple and most of the areola, and if they can't open their mouth wide enough, then sometimes they might only take the nipple, which can cause nipple damage, which can lead to mastitis, not to mention the fact that they're not taking in the areola, they're not pulling the milk actually out of the breast. So the tight frenulum right there under the tongue, if it's too tight, then they can't open their mouth. So they can it's easy, they just snip it with a pair of sterile scissors in the doctor's office. Yes, making sure they use their finger to remove their breast. They don't just pop baby off, because the suction will cause damage as well. So if they use typically their pinky finger and slide their pinky finger in between the breast and the baby's mouth, so it separates that suction. so that they don't just pop baby off, because that will damage the tissue. Oh, all of it. I remember doing that a couple times by accident, and it was not pleasant. So, good question. So let's talk about the positions. So when we're talking about the cradle hold, that's the one you typically think of, where baby is laid across mommy's front and is eating that way. That is good for what you call your general population. There's really no other circumstances that would prevent you from feeding that way. The other two can be, and it's not where the other two can't be used by the general population, it's just certain people that should use them. So for a cesarean, the best one, you can use a sideline, that one's fine, but the best one for a cesarean is the football hold, which is where baby is laid down the side of the mom, and just like a football, mom holds baby's head in her hand to allow baby to feed that way. This is also good for twins. So if you have twins and you have one baby feeding on each side, you can use the football hold, and that way they don't get it in each other's way. So twins and cesareans for your football hold. For your sideline is good for either mamas who don't feel safe holding their baby up. Maybe they've had some pain medicine or things like that where they're a little groggy. Or another reason, and more commonly that we use the sideline, is for women who have had perennial lacerations or are having a lot of perennial pain. If they have hematomas, or any reason that it makes it really uncomfortable to sit up on their bottom. This way they can lay on their side and they don't have to sit on their bottom, causing unnecessary pain. So cradle is good for everybody. Football hold is good for your cesareans and your multiples or your twins. And then your sideline is good for groggy patients who have had pain medicine, or for perennial pain. What do we want to tell mothers to never give their babies under the age of 6 months? Never, ever, ever. For any reason whatsoever. Honey is one of them. Yeah, we don't like them to get the flu either. So we don't want them to have water. So no free water under the age of 6 months. Even if it's hot outside and it's July and you think they are going to get dehydrated, don't give them any water. Exactly, because of seizures. Now, if they want to, they can give them Pedialyte or some kind of electrolyte replacement solution. That's fine. But free water doesn't have electrolytes, and their kidneys cannot concentrate urine the way an adult can, so that they are excreting that extra water without diluting their electrolytes. So they can get seizures because of the hyponatremia from being fluid overloaded. So no free water, making sure that if they're formula feeding them, that they are mixing it according to manufacturer recommendations, unless they've been told otherwise by a doctor, add that disclaimer. But sometimes we do have it where babies that have issues with gaining weight, we might make it more concentrated to increase the calorie amount compared to the volume amount, but it should never be further diluted. How many calories extra a day should a lactating woman have? Yes, 500 extra calories per day. How much extra fluid? Yep, so, well, typically about 1 to 2 extra liters. So usually about 3 liters is what we're looking at as far as total amount. They need a lot of fluids. And a lot of times when women have issues with production as far as breast milk, that's the most common cause, is they're just not drinking enough. And that will decrease milk production. It might not seem like that much. They might be like, well, there's not that much milk coming out of my boobs that I should need this much fluid, but that it really takes more fluid to produce the milk than they're actually seeing. So lots of fluids that they need push fluids, making sure that they are communicating with their doctor still, any medications that they're taking, even over the counters, even supplements. The gamut of what can be taken during breastfeeding is much more than during pregnancy, but there still are some things that can be transferred in breast milk and be harmful to babies. So they need to be aware that they're communicating that to their provider. Let's see, we talked about that. Normal newborn weight loss is up to how much? Very good. 5 to 10% of their birth weight. And when should they gain back to at least their birth weight by? Yeah, if over, it's a problem. When should they be back to their birth weight by at the latest? Yeah, 2 weeks. Usually 10 to 14 days is what they're talking about. Yes, a lot of times babies that are normal, I guess you would say, are well, I don't know about doubled. Usually you double by 6 weeks. 6 months, not 6 weeks. Listen to me, 6 months. But they should at least come, or you mean doubled as far as the loss to the gain. Is that what you mean? Like they should double how much they lost? Or do you mean double their birth weight? Well, they don't double their birth weight until 6 months. They double at 6 months, triple at a year. But they should at least gain back what they lost. Most babies gain more than that. And that can, if they don't gain it back within time, or if they lose more than 10%, they may need additional supplementation, whether it be NG feedings, if it's actually a suck issue, or if it's like a breastfeeding issue, they might need to supplement with formula or whatnot, some kind of supplementation. Yes. Yeah, that's exactly what causes them to lose that fluid. They have fluid volume shifts, all that extracellular loss, kind of like what mama loses a lot of weight afterwards. It's just a lot of that fluids. And loss of baby, baby coming out, the placenta, all that stuff that gets lost. Heat loss. So we talked about acrocyanosis. The hands and feet being blue means heat loss. So we're going to wrap them up. What are 2 other complications we worry about with heat loss, with cold stress? Yes, hypoglycemia. There's one more. Oh, not withdrawal. Withdrawal would be if they had received opioids over a period of time. Yeah, respiratory, very good. So respiratory distress. So they can get, if they have hypothermia, where they drop their temperature, they can get hypoglycemia as a result of that, because all the energy it takes trying to bring their temperature back up, it uses up their sugar stores, dropping their blood sugar. And then respiratory distress, again, because their body's working so hard to bring their temperature back up. That they can get respiratory distress. Remember, babies do not shiver and they do not sweat. So any thermoregulation maneuvers that we have as an adult doesn't work for them. So we have to provide them with that. We have to keep them warm, keep them wrapped up. If we do see them shivering or sweating, that is a sign of something else. With the shivering or the jitters, what could that be a sign of? It could be 2 things. Yes, hypoglycemia, that's one of them. They'll get jittery. What's the other one? Tina mentioned it in a different context. Yes, your withdrawal, your neonatal abstinence. So if they have the jitters, it could be either hypoglycemia or it could be neonatal abstinence syndrome or withdrawal. Now, if they have the sweating, that could be neonatal abstinence. With both of them, the neonatal abstinence as well as the hypoglycemia, some of the other symptoms you may see include your yawning and your nasal congestion with excessive sneezing. So if they're sneezing a whole bunch, newborns sneeze a little bit just because of all the fluid in their passages that they've taken in while in utero. But if they're excessively sneezing, that can be a sign of withdrawal or hypoglycemia, either one of those, as well as excessive yawning. You'll see that with both of those. They're kind of vague symptoms, but they can be signs of those.
Miss Martinez, so I was confused because this is like totally different, but it's not. So I was doing like some adaptive quizzing on circumcisions, but I know it's like different types. But I thought like we no longer use petroleum jelly. But I swear one of the answers said, I should have took a picture, but it was like use petroleum jelly.
It depends on the type.
Okay.
Yep. It depends on the type. So, like the two big ones you think of is the Gomco, which is, from what I understand, talking to some of you, that's the one that most of you have seen at HCA, if y'all have watched those, where they put basically the barrier in place and they kind of slice off the extra skin around it. And then there's the Plastibell, which is where it's a device where it puts this ring down basically to separate the foreskin away from the penis, and the ring is left on, and then it separates with it so that it falls off in like a week. So when you're talking about the Gomco, which is, and if they use Vaseline, I bet that's what it was. The Gomco, which again, from what I've heard from some of you, that's what y'all have seen at HCA. You do use Vaseline with it, versus the Plastibell, you don't use Vaseline with it. So it really just depends on the maneuver that was used in the circumcision type. So that's the biggest difference. How was it performed? But in all babies, what do they need to do before they can go home if they had a circumcision? Yes, they need to pee before they go home because we want to make sure there's no urethral obstruction. Now, with either type, yeah, exactly. Any surgery, even non-urinary surgeries, they always want to make you pee before you go. A lot of times they want you to take in some PO before you go just to make sure. As far as the other thing, one thing that you will see with potentially both types of circumcisions is crusting around the site, where you'll have like the serous crusting. That's normal. That's expected. You want to have that. It's healing. You want to make sure the parents don't pick that off because that can cause infection. Yeah, exactly. If it's just yellow serous crusting, don't remove that because that is the body trying to form a barrier and prevent infection. You also, scant bleeding. If there's a little bit of bleeding, that's okay with either one of them. It should be scant, though, not excessive amounts of bleeding. As far as specifically to the Plastibell, with the Plastibell method, again, they'll have this ring left on their penis that's holding the foreskin. You won't see this with the Gomco, but with the Plastibell, you will. That ring is going to fall off by itself in about a week. You don't want the parents to pull that off because that will cause problems. It's kind of like the umbilical cord. You don't want to pull that off. You want it to fall off naturally. The umbilical cord is kind of a little bit longer, but similar time frame. Umbilical cord is about 7 to 10 days, and you want to make sure that it falls off naturally. What do we clean an umbilical cord with? Yeah, just water. maybe a little bit of soap and water if the umbilical cord gets soiled with stool or whatnot, but overall it's just water. We don't use rubbing alcohol anymore because it dries out the skin around it, which can crack the skin and then increase risk of infection, even though it is an antiseptic. So maybe a little bit of soap if needed, but overall just plain old water. Keep the site dry and open to air, making sure the diaper is below the umbilical cord site, so either that it's got the little cutout like the newborn diapers, or you can roll the diaper down so that it's below where the umbilical cord is. Yes, very good. So let's talk about hip dysplasia while we're on there. So hip dysplasia, what is some of the symptoms you'll see with hip dysplasia? Yes, that one side that's affected will be shorter than the other. Yes, you'll have trouble with abduction of whatever side is affected, which means you can't move that hip outward. You'll also have where there'll be asymmetrical gluteal folds. So when you look at, or even on the thighs, you'll see where it'll be a different number of folds, but you'll see the imbalance in the gluteal folds. You'll also have that positive Ortolani sign. So the diagnostic test they use for hip dysplasia is called the Barlow and Ortolani maneuvers. Yes, exactly. So the Barlow is the first test where you're trying to dislocate that hip. And in most babies that don't have hip dysplasia, you're not going to be able to dislocate that hip with normal pressure. If you do, the Barlow, you're not necessarily going to feel anything as you dislocate it, but when you do the Ortolani part where you're trying to reduce it back in, if you feel a click, then that hip click is where you're popping that hip back in, and that means that it was dislocated to begin with, a positive sign of hip dysplasia. So positive Ortolani sign is bad because it means they have hip dysplasia. So most common treatment for this, like you mentioned, the Pavlik harness. They wear this usually 23 hours a day, so all day except for, like you mentioned, when they're taking a bath, maybe if they need to change the diaper, things like that. But overall, they wear it all the time, usually for about a month or two to see if that helps. It will help strengthen the tendons and ligaments as well as deepen that pocket that the acetabulum fits in so that it won't pop out as well or as easily. Let's see. When is the best time to perform a newborn screening test? Like how long after birth? Yes, at least 24 hours after. Ideally, it should be even longer. 2 to 3 days is even better. But, I mean, how many babies are still in the hospital at that point? Yes, you're exactly right. They need protein. So at least 24 hours later than from birth, because they need that protein in their system or anything else they're being assessed for. So there's PKU is what we think of. So at least 24 hours afterwards. So PKU is the one we think of, but any of those metabolic diseases, it will affect it. So PKU, your galactosemia, your maple syrup urine disease, those are some of the big ones you think of. All of those require the ingestion of whatever the baby can't break down in order for those byproducts to build up for the test to be positive. So if you obtain the test too soon, it will be a false negative. Yes, very good. So with your PKU, your phenylketonuria, you need low protein diet, no diet, any kind of artificial sweeteners, because that's what is in diet soda that is has the phenylalanine in it. So there is a special formula called low-phenolac. Low-phenolac is the name of the formula that babies with PKU need. It's a low-protein formula so they don't develop complications. Complications being brain impairment, cognitive impairment. So they can get brain damage and cognitive impairment if they are consuming too much protein and those byproducts are building up on their brain. And that's what you see with a lot of the metabolic disorders. If they're consuming whatever it is that they can't digest appropriately without building up those byproducts, it causes brain dysfunction. I think what else did we talk about? Pre-op care for a patient with Spina Bifida or Myelomeningocele. What do we want to do? What position do we lay the baby in? And what do we want to do to the sac? Yes, prone positioning. We want them laid on their bellies. Yes, and we want to keep that sac moist with sterile saline-soaked gauze so that it doesn't dry out. Yes, white blood cells, Gabby, like you mentioned, may not be good for, or a good indicator for mom as well as baby. Both mothers and newborns can, for the first couple weeks, have an elevated white count up to 30,000 that doesn't indicate an infection. It's just the inflammatory process of going through, this major life event. Yes, that is a huge risk of infection, is if that sac that contains that meningocele or myelomeningocele ruptures. So we want to make sure we're protecting the integrity of that sac until they go to the OR, so that way it doesn't rupture. Monitoring them for signs of infection. Remember, with babies, one thing kind of going back to vital signs, babies are not always going to have a fever. In fact, it's more common, instead of a fever, for them to either have a low temperature or temperature instability. So that lower temperature is more significant, not necessarily more significant, but more likely that you will see than a fever. Yes, or even respiratory distress, absolutely. Let's see. I think what else we talked about. I think y'all remember a thing or two, or maybe even 5. I think y'all will do all right. That hits a lot of, I can't think of anything else to really, anything else y'all had questions about? Or anything else that comes to mind you want me to talk about again? Even if you understand it? Good question. Yes, crosses suture lines. So caput succedium crosses suture lines. The easiest way to remember the characteristics of caput succedium versus cephalohematoma. The caput succedium crosses suture lines. Think of it like a cap that sits over the head. So it's generalized, it sits across the head. Versus cephalohematoma is more localized. It's not going to cross suture lines. This is a collection of blood, it's a little bit deeper. This does not cross suture lines, so it's localized. Think of a hematoma, it's more local. Caput, think of a cap, like a cap you wear on your head. Yes, hydrocephalus. So hydrocephalus is, it literally translates to waterhead. So this is where they have something that's prohibiting the reabsorption of the CSF in the ventricles. in this case, talking about newborns, we're talking about some kind of congenital problem. So there are many different reasons for it, and this is where they will need to get a ventriculoperitoneal shunt, or a VP shunt, which is a tube that snakes under the skin, down the neck, and empties out into the peritoneal cavity. So that way all that fluid doesn't build up in their head, causing increased intracranial pressure as well as expansion of that head. This is why children get head circumferences up to the age of 2, where they're measuring for things like hydrocephalus. So molding, yes, is where they, and this is normal, molding is entirely normal, it goes away. It is where coming through the birth canal, because of the way the head squeezes through, it squeezes the head together at the end. We'll call them cone head babies. And this will go away within a couple weeks, at the most, usually earlier. It's just where the head is conforming to the birth canal, so baby will fit through. It's not concerning. That is one thing I've heard people say. That's why they like having C-sections, not only because of going through labor and birth, but baby's head ends up prettier. I mean, it goes back to normal. It's not unusual. So, but yeah, molding is where the head squeezes to fit through the birth canal, and then it levels back out within a couple weeks or so. Those are the big 3 head, or 4 with hydrocephalus. There's else we've talked about. Y'all think of anything? I'm gonna flip through my notes and see anything I can think of. I don't know why. We've only been talking for 5 hours. Yes, ma'am, Kalia.
All right, so this is like a general question related to surfactant. I just want to know, like, is it synthetic, or is it like maybe donated from other babies? Like, how do they get
Usually it's synthetic.
Okay.
That's a great question.
Thanks.
Yeah, usually it is synthetic. Let's see.
So, Miss Martinez, just to jump ahead, so next week's tutoring will be like exam 3 material, or like proctor stuff.
Yeah, basically anything that you have questions about, absolutely, bring it on. But because that's probably going to be it's going to depend on who's there. The evening class will probably, if anybody from the evening class shows up, they're probably going to be focused more on, exam stuff, which can help with the proctor as well. But more than likely, next week's tutoring is still going to have a maternal newborn focus, and then whether it be the day class worried about the proctor, or whether it be the evening class worried about exam 2, and then the following week we'll focus more on pediatric stuff. So either way, whether you're taking worried about the proctor or exam 2, it'll still be information regarding maternal newborn still. Although I take any questions that you have. Whether I can answer them is another question.
Can I ask a question about the project?
Yeah.
The growth and development section, you talked about it a little in class, but if you're doing like the mom, because they don't have like the Piaget and, well, they do have, well, like, so what stages would we talk about, or or just what?
What's that? You muted yourself.
Oops, what stages of labor and delivery, or like, because they don't have
whatever growth and development stage they're in. So they're through their lifespan, even as an adult.
Oh, as an adult. Okay, so like an Erickson stage, like that kind of.
Yep.
Okay. Okay.
You might have to dig out the lifespan book a little bit.
Okay.
Absolutely. Ooh. You know what? If you're doing, you should do at least list a large portion of the labs. So maybe not say the CBC differential if it's not pertinent, but at least when you're talking about the CBC, the big ones like your hemoglobin, hematocrit, red blood cells, white blood cells, platelets, the big ones. So you'll have to use kind of your thought process to identify what is most pertinent to this patient. Now, if you have a patient who has an infection, for example, that differential is important, and you should include that. But use your patient and what's going on with your patient to identify what you need to include, I guess, is what I'm saying. That's what I done earlier. Who was here? Yes, Hep B is the first thing they get that requires consent. Erythromycin and vitamin K don't require consent. It's considered part of your global consent of care. But hepatitis B, because it's a vaccine, requires its own specific consent. What do you mean specific boxes? Like a box for each lab, or a box in general for lab values? Oh, yeah, and that's fine. I would recommend using the table function. So, hold on. Let me file to, hold on. Let me share my screen. I have too many documents open. So when you go to insert table and say, however many, you can either do individual, or maybe you want to do one box with your CBC, one with your BMP. I don't know why my brain couldn't think of the word BMP, but or if you want to do individual ones or just one, and then however many you want to go across. So just adding tables that way into it would be the easiest way.
It's not necessarily like a page maximum, as long as we go by the rubric and hit every point. That's all that matters, even if it looks short.
Yep.
Okay.
Oh, I thought I hit. Never mind. I don't know what it is. But yeah, to go back to your question as far as, or not question, your statement, Gabby, about neonatal blindness. Yes, that's why we give the erythromycin, to prevent neonatal blindness from chlamydia and gonorrhea. Yeah, so if you did a Cumberland patient, they would have admission labs, so that's what you can put in. They're not going to continue to have updated labs usually unless something comes up. So just whatever their admission labs were. Yeah. And a lot of times it's just, if any of you, which actually, Bonnie, you work in the ER, so you probably know this. Whenever we have patients that are admitted to a psych facility, we always have to get basic labs, CBC, BNP, that kind of stuff, so that they can exclude any kind of medical causes for their behavior before psych facilities will take them. So even psych facilities will have a basic lab component that are done, say, in an ER or admitting facility before they go to the psych facility. Yes, 3 to 4 weeks. Actually, I thought ATI said 30 days. I might be wrong. But yes, it's definitely, you don't want to get pregnant right away. Yeah, the full medical screening, exactly. Because they want to know that there's no medical underlying concern. And I will give you an example. We had a patient who was acting funny out in the parking lot. He was laid out in the parking lot. His family wanted him to be seen, but he was refusing. The cops finally arrested him, and they arrested him just so they could take control of getting him seen in the ER, because he was not acting right. He was acting not really belligerent, but like I said, laying out in the parking lot. So when we brought him in, we figured, and he had a psych history. He's having some kind of psychosis. Let's look into having him evaluated for admission. So, of course, we do our initial lab work like we do on every patient, and his sodium was 124. Because he had, because of his psych medications, some psych medications can cause you to drink water excessively and give exactly water intoxication. So he had given himself water intoxication, and his symptoms were related to that. So that kind of is a great example of why we check physical stuff before we admit them for psych. But every psych facility requires a basic medical exam with labs. So even Cumberland, they should have, even if they've been there for 5 years, they'll have at least one set of lab values on admission. I think y'all will do great. Y'all seem to know your stuff. This gnat will not leave me alone, and I can't catch it either. One gnat. Sure. Okay. All right. Do y'all have any questions for me? I know we've covered a lot of information, and especially if you were in my day class, you're probably fried by now between class and tutoring, which is great. Hopefully you got a lot of information. If y'all don't have any questions, I'm going to let y'all go so y'all can either get to dinner or get you something to eat before class or whatnot. But I will see y'all next week. Oh, you're welcome. Or I may see you Saturday. If you have clinical Saturday, I'll see you then. You are welcome. Y'all enjoy your time and take care. And yes, I will see some of you at 6:30.